let's start with a little bit of history, which I think is important for setting the stage, which is to remember the health debate circa the early 2000s. Remember, we've been trying to reform healthcare in the U.S. since the early 1900s. Teddy Roosevelt was the first one who tried to do it. And along the line, we'd become stuck between two extremes. One extreme was people on the left who believed the only answer was a single-payer healthcare system, which has a lot of advantages, but has key political disadvantages. Most notably, most Americans are pretty happy with their healthcare system and weren't really in favor of ripping it up and starting over. On the right, they said, well, we have a system that works well for most Americans, let's just keep it and maybe have some tax subsidies or something. That had the problem that it didn't solve the fundamental failure in our system in America, which is if you do not have employer-sponsored insurance and do not have government insurance in America, you do not have insurance. There is no meaningful option outside employer and government insurance in America. But by that I mean if we define insurance, that means no matter how sick you get, as long as you pay and you're healthy, you're covered. That doesn't happen for people who don't have employer insurance or government insurance, because if they've had cancer, they can't get that covered. If they get sick, they can be dropped and have trouble finding new health insurance. So the problem, the solution on the right did not help the 50 to 80 million Americans who suffered in this sort of nowhere land between not having employer or government-sponsored insurance, and therefore most of them were uninsured. So into this void, after almost a century, stepped the hero of our story, and let's call him Romney 1.0. Okay, Romney 1.0 developed that elusive third way. We always talk in public policy about the third way. He really developed it, something I like to call incremental universalism. Incremental is not a new religion. Incremental, borrowed from the right, meaning let's build on what works. Let's leave people alone if they're happy with what they have. We had a very high employer insurance coverage in Massachusetts. We left that alone. Universal, borrowed from the left, meaning let's get to universal coverage. And how did Romney 1.0 propose to do that? He did by essentially building what I like to think of as a three-legged stool. The first leg is insurance market reforms, to end the ability of insurers to exclude pre-existing conditions and discriminate against the sick in the issuing and pricing of health insurance. Now that actually turns out was in place before Romney in Massachusetts. That was in place since 1996. And Massachusetts was one of 7 states in the mid-90s that tried to do this well-meaning reform, and in every case it was a disaster. Because you can't tell insurers that they have to insure everybody, but let people wait till they're sick to buy insurance. I think the analogy I best recently, because I'm a big sports fan, is it's sort of like telling a sports bookie they have to take bets at halftime. Okay, a sports bookie has to take bets at halftime, is going to go out of business because people know who's going to win at halftime, and they lose money. It's the same thing with insurers. If you tell them they have to sell to everybody, but let people wait till they're sick to buy, they're going to go out of business. That's why I need the second leg of the stool, which was the individual mandate, to get the healthy and the sick together into the pool. But if you can't mandate people buy health insurance they can't afford, and that's why I need the third leg of the stool, which was subsidies to make health insurance affordable. This law has been a great success. We've covered 2/3 of the uninsured residents of Massachusetts. Our uninsured rate is down to about 3% compared to a national average of about 18%. We fixed our broken non-group insurance market, lowering premiums by about 50% for people buying insurance on their own relative to national trends. We've done so with significant public support. There's about 2/3 public support for the Massachusetts law, and it's been very successful law. And as a result, it was the model. Just make no doubt. I mean, Ron equivocated a bit. There is no doubt it was the model for the Affordable Care Act. And I can say this with certainty for a couple of reasons. First of all, it used a very similar set of advisors. Myself, Stewart, John McDonough, John Kingsdale, who ran the connector. We shuttled back and forth between Washington and Boston, and as even Rick Santorum pointed out during the debate, they had White House logs where John Kingsdale and I had signed in a number of times to visit, going back and forth to discuss what we'd done in Massachusetts, how it worked, why it worked, and the number of times I got asked, how did you do this in Massachusetts, what worked, what didn't, is enormous. Make no mistake, it's the model. And if you don't want to trust me as a source, just look at the words. The laws are the same. It's the same three-legged stool. Fixing insurance markets, mandating insurance coverage, subsidizing insurance coverage. As John McDonough said, my favorite quote of his, he said, look, it's the Massachusetts law with 3 more zeros.
Whoever you want.
Yes, for Mr. Gruber. I have 2 questions. First is, you've been quoted as saying that premium support is ultimately where we need to be, which sounds like you're in favor of vouchers. And so I'd like you to explain what you mean by that. And the second is, on single payer, you said that it was, to paraphrase, it's politically impractical because Americans who have insurance like their insurance, and they wouldn't want to move to that kind of a system. But you didn't say anything about the health insurance companies, which would be wiped out and which have political power and don't want a single-payer system. So if you could address those two questions.
Sure, yeah, on the second one first, you're right. I mean, there's two fundamental barriers to single payer. The first to mention, the second is the $850 billion a year private health insurance industry, which is not going to go quietly into the night. So I agree. I think there's just multiple reasons why single payer isn't happening, which is why I think the solution from Massachusetts was so exciting. And one thing I'd emphasize, you know, I realized later, I can't think of an example in our history where we've put in such a major policy at the national level where we actually ran the experiment first. I mean, the Affordable Care Act, we ran the experiment in Massachusetts. It's worked, and that's kind of a neat feature for a scientist like myself. That's kind of a neat feature to see. In terms of premium support, yes, I think ultimately we could, as a nation, and probably should, move to a model ultimately really where there's a basic guarantee for everyone, and then people who want to buy up can buy up. I think that's sort of the American way. I think we're not going to be like Canada where everybody's forced on the same plan. I think ultimately we're going to have to recognize in America that we have a two-tier healthcare system. Right now it's an implicit two-tier healthcare system where people who happen to have insurance get good care, people who don't happen to have it get bad care. I think we need to recognize everyone needs to have good care, and then if people want to buy up and have excellent care, we're going to let them. And I think that's where we need to be. The difference is, what frustrates me about the Ryan Romney approach on that is two things. First of all, we have two groups we're talking about right now. We have the non-elderly uninsured for whom the system is broken, and we have seniors for whom the system works. Face that, why would you want to experiment on seniors and take this away from non-elderly? The Affordable Care Act puts in exchanges and competitive premium support system for the non-elderly. It does so in a rational way, and then we're going to see what works. We're going to have 50 different exchanges. We'll see what works, we'll learn, and then ultimately we can take those lessons and apply them to seniors and think about slowly phasing in for the Medicare program. I'm not opposed to that. We're about to run this great experiment. We're going to actually learn how this premium support system works nationally with many different models. Let's do that. Why do we, you know, and I was really influenced here by an excellent article by Henry Aaron and Austin Fracht in the New England Journal about 8 months ago. And Henry Aaron is one of the original premium support advocates, developed the idea. Basically the theme of the article was, look, where's the fire? I mean, basically, we've got a long-run cost problem. It's been going on since 1971. It is never, ever, ever going to end in the history of our nation. Okay, we're going to struggle with healthcare costs forever. Okay, why are we going to rip up a program that works in Medicare when we're about to experiment for a population where it doesn't work? And let's see how premium support effectively works for non-elderly, and let's bring those lessons along to make them work in Medicare.
All right, and just a quick follow-up. So you're saying premium support is ultimately where we need to be. So you're saying that's for Medicare also?
I think ultimately we need to be, I don't know if I want to use those words, ultimately we need to be in a system where we recognize that there's a minimum that everyone should qualify for, that's a good, acceptable minimum, but that people should be able to buy up, have options to buy up, and that's what premium support effectively gives you.